Sir, when you asked about problems in graft angio, we are actually getting many chances to graft angio, sir.
See, your audio is not so clear. I mean, keep it close.
Sir, we don't get many chances to do graft angios. Very occasionally we try, sir. We often find that the right graft, it is relatively easy to engage. We regularly use a multi-purpose catheter. It easily goes and sits into the graft.
Yeah.
Always the left grafts, not even once I was able to successfully engage the graft.
Yes, I mean that's a usual difficulty even I had in first 1.5 year of my post DM phase, and also Lima. So how comfortable you are in engaging Lima or cannulating Lima?
If we only once they have given me chance for engaging Lima. That was through the left arm. So
okay.
It was
that is very easy. Yeah.
And it was not a
See,
problem.
engaging internal memories from respective hand is very easy. If it is right, obviously the best way of cannulating Rima is through right hand. From femoral, it is very tough engaging Rima. I mean, many times we have to use some techniques to cannulate Rima.
Yes, sir.
Yeah, that's a very common problem, cannulating left grafts. And see, I'll go through the anatomy of the left grafts. I mean, all grafts basically in general, and how they are different, and how their position in related to their routine left system, and a right graft with the right system. So all those relations I'll show you with CT pictures. So why we face problem, and most often it is the view, so in which you are trying to cannulate, it is important. So if you choose a right view, obviously you can cannulate it easily, quite easily. Hi Nag.
Yeah, am I audible?
Yeah, you are perfect.
Good. Nice to see you here. Yes, come on.
Yeah. Hey, Dr. Nagaraj, for rest of the audience, participants, Dr. Nagaraj is a cardiologist who is my batchmate, and so he is now practicing in Tirupati. He's the owner of Sankalpa Heart Institute.
One of
So Nag, so we will see while people are joining. I mean, so far we have some 14-15 participants, about 20 participants. So people are joining. So we are just as a preamble to my presentation, we are just discussing about difficulties which we face in doing graft angiography routinely, routine difficulties.
Yeah, good.
So that we can try to discuss those things in while going through the presentation.
Yeah.
And sir, one more thing which I often find difficult is the RCA graft is easy to identify, and it's easy by the anatomy to identify which vessel is filling. But the left graft, whether it is the OM or a diagonal, or which is the graft which is the artery which is being filled, only with the graft, I often have difficulty to sit in the console and see again and again.
It's a very good question, Anand. Many times the problem comes with a venous graft, whether it is going to diagonal or ramus or OM. So that is an area which is very difficult to differentiate. In fact, I am going to show one case today, similar case, at the end of the presentation, where in decision-making part in post graft angiogram, I'll show a similar case where I had a problem because in their surgery notes, they mentioned they grafted OM.
Okay, sir.
They grafted OM. So, but there was something different in angiogram. So, which I'll show you.
Okay, sir.
We are going to address that also in our presentation today. Nag, any specific issues which you had, in your graft angiograms, which you want to share before we enter presentation?
Not much. See, graft angios I did only few.
Yeah.
But there have been once or twice where we did not even have information of what are the grafts connected.
Yes.
Sometimes are not there.
Yes.
Sometimes when we have to do it blindly. So
Yeah.
what sometimes we did a couple of times is in such situations. To start with, the first thing what we did is aortic root angio.
Yeah.
Instead of poking and going around with a lot of things, the first thing we did is, and after like native coronaries, after doing the native coronary angiogram, first we did the aortic root angio, and then going for surgery after that.
Yeah. So in my practice, what I learned in last 5 years, if I don't have any information on grafts, at least even number of grafts,
CT angio is better.
I would love to do a CT angio. I mean, I don't do conventional angio.
CT angio is better. Like
it is very difficult. See, in fact, even analyzing data becomes very difficult. If you do a CT angio, and if you get a basic information of the graft, then in conventional angio, what happens? Sometimes I don't even inject into grafts. If I make out a good graft, I mean, if the graft is very good, say for example, there is a venous graft to RCA, it is very good in CT angio, I don't even inject.
Correct.
And if there is a graft to OM, so which is very good, so there is no suspicion in CT angio, then I don't even inject also those grafts. So in a way, it saves your time, saves contrast. In fact, that is good for patient also, rather than playing with catheters in his ascending aorta. So
in fact, CT angio is useful for a graft patient because the amount of contrast and radiation also will not be more. That is an advantage. Like whether it is a graft or regular angio, it is the same amount of contrast and the radiation.
The amount of contrast is same. Whether you do simple native coronary angio or graft angio, it's only 80
in the conventional angio, there is a lot of difference in the contrast and radiation between the regular and
angio. So it's only 80 ml.
Correct.
Yeah. So we'll start presentation. We'll begin presentation. If everyone is okay, we'll begin presentation. And mute yourselves. See, when if you want to ask anything, or if you want any discussion at that point of time, you can unmute and you can talk. So otherwise it will disturb our presentation. So we'll go ahead.
Can we record the presentation?
Yeah, we are recording here. You can't record.
Okay, that's fine.
See, we are recording here, which will be uploaded to our website, Strategies website.
Okay, I'm unmuting myself.
Yeah. So, okay. See, today's topic is basically, taming grafts. No, it's basically, understanding the anatomy and so making your cannulation capability more effective. So that is the goal of today's presentation. So why we have to do a graft angiogram? See, it is basically post-operative ischemia. So it's a post-operative ischemia. So again, in post-operative ischemia, so we can divide it into early and late ischemias. Again, early one less than 1 month, and 1 month to 1 year. So the reasons are different in these situations. If you see the early post-operative ischemia, that is less than 1 month. So the most common cause is acute vein graft thrombosis. 60% of the times, this is the cause for early post-operative ischemia. The other common cause is incomplete surgical revascularization. This is happening quite frequently, especially this scenario of arrogatory and beating heart surgeries. Increasing beating heart is sometimes surgeons are giving concession to grafts. So they graft main vessels and they leave branches. So incomplete surgical revascularization contributes to significantly for early post-operative ischemia. And another is kinked graft. So if the length of the graft is not chosen properly while doing surgery, grafts can kink. So this also causes, this commonly happens with, venous grafts. Next is focal stenosis distal to the insertion site. So this is another thing, whenever there is a diffuse disease, so whenever you send patient to surgery, always, try to, explore whether, this patient can have a good graft or not, because sometimes they'll have a diffuse disease, even surgeon grafted, the oral flow may not be sufficient. And focal stenosis at the proximal or distal anastomotic sites, and spasm or injury, and this is most commonly, this happens immediate post-op phase. So it is in first 24 to 48 hours of, post-bypass surgery phase. That's where you face this spasm or injury. And insertion of grafts to a vein. So I have seen one case, so where graft is inserted to, posterior descending vein, so which accompanies, PDA. So insertion of vein to and causing AV fistula and bypassing of the wrong vessel. So these are the common causes of early postoperative ischemia. Predominantly, it is the acute vein graft thrombosis or incomplete surgical revascularization. And most often we see this early postoperative ischemia in 24 to 48 hours. And next is, from 1 month to 1 year, so where the commonest cause being, perianastomotic stenosis. Again, it is basically the distal anastomosis technique. So, distal anastomosis failure, which is the commonest cause for, early post-op ischemia, that is 1 month to 1 year. So these patients, they manifest from 1 month to 1 year. Typically because post-bypass patients, they become active after 1 month, most often. So that's when they start feeling symptoms and, they come back for re-evaluation with some exertional angina. And next is the graft occlusion, that is a venous graft occlusion. Another is, mid-SVG stenosis from fibrous intimal hyperplasia. So this is very important. Venous grafts, there are two kinds of occlusion. One is fibrous intimal hyperplasia. Another is, atherosclerotic degeneration related occlusion. So the early occlusions of venous grafts predominantly because of fibrous intimal hyperplasia. So because in these situations, the expansion of your stents is a bit tough. But in degenerative grafts, expansion of stents is very easy. But the embolization is more common. So in fibrous intimal hyperplasia, expansion is an issue, but there won't be any embolization. But degenerated old grafts, embolization an issue, not expansion. Next, distal graft anastomotic lesions. Coming to the late postoperative ischemia, that is beyond 3 years after surgery. So in these most common causes, basically new atherosclerosis. Either new atherosclerosis in the grafts or new lesions in new locations of native vessel. So this is a common cause for postoperative ischemia beyond 3 years. Anyway, these are the situations why we do angiogram. So see, while doing graft angiography, see, what we should really understand is the anatomy of the graft. If you understand the anatomy of the graft, then so cannulating and visualization of graft becomes very easy, and also visualization of distal anastomosis. So for whole thing becomes easy if we understand the anatomy. So I'll just go into graft anatomy. I'll try to make you understand with a surgical picture and a CT angiography picture.
This is
angiography pictures and so CT angiography. Please mute yourselves. So it is disturbing. So please mute yourselves. So CT, I'll compare with a surgical picture with CT angiography and as well as our conventional angiography to understand the whole anatomy of the grafts. So to understand graft anatomy, so we have to understand three things in the graft. One is proximal anastomosis, second is the course of the graft, and third is the distal anastomosis. So I'll go to the proximal anastomosis of grafts. So see, in proximal anastomosis of the grafts, you can see this is a reconstructed film of CT angiography. So in this, you can see the grafts. There are two venous grafts. So one is going to left, that is a left venous graft, and another is a right venous graft. And this is an exact anterior view of the heart. So you can see on the corner, lower right corner, so the which indicates actually it is the anterior picture. So this A indicates, it is an anterior view of the heart. So if you see, the right-sided grafts are on right anterior aspect of the aorta, and left-sided grafts are on left anterior aspect of the aorta. So when I was in DM and even immediate post DM, so generally we tend to understand right-sided graft means it is located close to somewhere, right coronary artery, and left-sided graft means it is located somewhere close to left coronary artery. So this is, it's a myth. It is not true. So I will show you in cross-section images of CTs to understand, the angle between left system and left grafts, right system and right graft. This is a surgical picture. I think, if anyone has any questions, you can unmute and you can ask, because this is the most important thing which we have to understand. This is the live surgical picture, anterior view. There are three grafts if you see, right? So see, this is the first left-sided graft. This is the second left-sided graft, and there is a right side graft. I hope all are able to appreciate. So if you see the left-sided grafts, so left-sided grafts are on left anterior aspect, and if you see the grafts which goes to anterior aspect of the heart, that means LAD or diagonal. So those grafts are caudal and more anterior, and the grafts going to posterior vessels, that is obtuse marginals, branches of left circumflex, are more cranial and towards left. And sometimes if there are more than 3 to 4 grafts, the most cranial graft is to the most distal branch of LCX, and the most cranial branch is as well lies on the inner curvature of the aorta. So this is the most important thing which we have to understand to play with cannulation of the grafts. I hope you understood. So the most caudal comes to the anterior vessels, most cranial goes to the most distal branches of LCX, and right-sided graft is pretty simple. It is on right, lateral aspect, and very rarely, surgeons may give even in posterior aspect. So that is in this area. Otherwise, usually it is in the anterior aspect of the right anterior lateral aspect of the aorta. So I'm just showing a CT angiogram transverse plane of a CT angiogram. I'll just play and I'll stop it and I'll show, the location of grafts. In this patient, he had one left graft and one right graft. So I'll just play and show you. You can see these are the 3 arch branches joining at the arch. And this is the ascending aorta. And this is the ascending aorta. Can you see? See, now I am coming above downwards. This is the first graft. So this is the first graft. So always most cranial grafts goes to only left side. I mean, if patient had both left and right sided graft. So this is the first graft which is going to left side. In fact, it is going to left OM. And this is the next graft. So which is visible on right side. See, this is right side and this is left side. So left graft is actually exactly on anterior and the right graft is on right lateral aspect of aorta. So this is the right graft and which goes and joins, RCA. So you can just follow the codes. So this is the right graft codes and which goes and joins. So RCA. So these are transverse planes of CT angiography, in which you can clearly understand the most cranial one is going to left side, and caudal graft is going to right side. So now I'll just compare our left grafts versus left system, that is LMCA. You see, this is the first picture. Your left hand side picture is the transverse section at the level of graft to SVG graft to OM. And your right hand side picture is basically, it's a transverse section of aorta at left main coronary artery origin. If you observe the distance, I mean the angle between the origin of LMCA and origin of venous graft to OM, in fact there is almost 90 degrees angle, nearly 90 degrees. So that is the reason, so that myth of thinking left-sided grafts will be placed close to left system is basically wrong. So there is a huge difference in the location of left-sided grafts when compared to native LMCA. That is the reason that conventional guide catheter, which works for left system, it won't work for our left venous grafts. That JL, it won't work for left venous grafts because of this, because exactly it is located 90 degrees from left system. Yeah, this is another patient with with a venous graft. This is the left venous graft, almost an anterior location on the aorta, and the right graft, so nearly so something like posterior location when compared to venous graft, with a nearly 90 degrees angle, so in a transverse plane. So that's the reason, cannulation of venous grafts with the conventional Judkins left is very, very difficult. You can't, I mean, it's almost impossible, which I used to try. The reason is, and another thing, see, if you look at the plane, see, normally to locate, for cannulation of a vessel, you need to locate vessel first. So normally we locate left and right system in an LAO view. Why? Because, so this is how LAO view shows your aorta. You can see this yellow line on the aorta. So this is how LAO view looks into your aorta. So in this view, so your left system is sitting on the extreme side and right system sits on the extreme right side. So that's the reason you can make out these vessels and you can cannulate. But if you see this, left venous graft. It is exactly in the middle. So it is not at the extreme location. So that is the reason. So cannulation in LAV view, I find it very difficult. So, but in a steep LAV view, we can try, but most often I do RAV view. If you take RAV view, this is a RAV view. How, RAV view, RAO looks into your aorta. This is, second one is how LAO looks into aorta. So this RAO looks into aorta so that your venous graft lies on the extreme anterior side. So in an RAV view, you can locate your venous graft of left system on the anterior side of your angiographic frame. I hope you understood this difference between LAO and RAO. Yeah, you can see how I'm cannulating in this case, but I'll come to cannulation later on again. So this is an RAO view. So in an RAO view, I'm facing my tip anteriorly. Tip is facing anteriorly, and I'm just pulling the catheter back. It just goes and engages your graft. So you don't need much, manipulation of catheter. So use this simple technique. Most of the times it will be successful. So this is how understanding this anatomy of graft location will change your makes your cannulation job very easy. Yeah. So again, in this proximal anastomosis. So in this proximal anastomosis, see, visualization of proximal anastomosis also important while doing angiography. Most often we find it difficult to locate ostium or to see whether there are any lesions in the ostium. So you can see the CT angio. If you have a CT angio of a particular patient whom you are going to do a graft angio, so what you can do a reconstruction, and you can see that reconstruction frame in various angles, and you can decide which view is right for that patient. So in this patient, you can see this is the venous graft, right? Left venous graft, and I am in a right RAO view, almost RAO 42 degrees. RAO 42 degrees. You can see it in the left bottom corner. RAO 42 degrees. RAO 42 degrees. So in this, you can see the venous graft is coming out straight from aorta. So this is the ideal view in which you can clearly see, you can face your catheter anteriorly and you pull the catheter back, so it just hitches into your venous graft. But also this is the view in which you can clearly see the ostium in angiography. So I'll now come to the right venous grafts location. So proximal anastomosis of right venous graft. So you can see this is the native RCA, which is seen caudal, and slightly almost in the same plane when it comes to coronal. So, and this is the right venous graft, which is located on right anterior and lateral aspect of the aorta. So if you see, so this is a surgical picture, where you can locate, this is the right venous graft. And if you see, right coronary artery is also exactly below this appendage. So, closing the right coronary artery. But I'll come to the transverse pictures where I can show you. Yeah, here you can see the right venous graft where appendage is lifted up. So this is the right venous graft. So, and I'll come to transverse pictures of CT angiography, which where you can identify the angle between right coronary artery and right venous graft. So you can see in this aorta cross section, so this is the right coronary artery, right? And the second picture is basically right venous graft. So if you see the right coronary artery and right venous graft almost located in the same area, maybe within 20 to 30 degrees of arc of the aorta. So that is the reason. So the visibility of right graft is much easier, and cannulation of right graft is much easier because it is almost similar to your right coronary artery when it comes to location on aorta. So cannulation becomes much easier, but the only issue with this, see this is LAO view. So you can understand, see LAO view, you transect aorta like this in our conventional angiogram. So wherein you can see RCA at extreme angle on right side of your angiographic picture. So also your venous graft is located in the same place. So that's why LAO view is enough for your right venous graft cannulation or right venous graft osteal identification. So yeah, I'll just show a picture. The only challenge which comes in right venous graft is, you can see in this surgical picture. So see, if you see the course of proximal venous grafts, you just compare the venous graft of left venous graft course proximally and right venous graft course proximally. I want all of you to see this picture and understand. So left venous graft, after origin, it almost goes transversely. But when you look at right venous graft, it is straight downward. So this is the challenge, which I face many times with the right venous graft. So conventionally, we think, JR is a right, with the JR we can engage right venous graft, but many times it becomes difficult because it is facing, it is angling directly downwards. So as if, in this case, you just see it just immediately after anastomosis. So it takes a downward course. So that's the reason JR becomes, sometimes very tough to engage. So your MPA works because of its, downward looking chords. So that's a challenge with right graft. Location wise, right venous graft is very advantageous in terms of cannulating, but course wise, proximal course is a bit, downward course, so which poses challenges while cannulating. But when it comes to left venous grafts, location wise, it poses challenge to cannulate. But see, once you cannulate, your catheter will be quite stable in left venous graft. So for your subsequent procedure. So again, right venous graft course. So I think already we have discussed. So I'll go to the course of the graft. So far we understood the proximal anastomosis of grafts, that's a venous grafts on left side and right side. Now I'll go to the course of the grafts. This course of the graft is very, very important to choose the plane or to choose a plane to visualize complete graft. So if you understand, when you start doing angiograms, the first thing which you have to understand or learn is the planar positions of angiography. So the planar position, see, basically your right coronary artery and left circumflex artery is something like atrioventricular plane. They are located in that plane. So, and your left anterior descending artery and PDA are located in a interventricular plane or septal plane. So why this planar understanding is important is, so this gives you an ideal view. See, wherever you want to visualize entire artery, entire vessel in one view, so your view should be perpendicular to the plane in which that artery is present. So I hope everyone understood this point. So your view, the ideal view to visualize any artery, not only bypass graft, is the view which is perpendicular to the plane of that vessel. So what you have to understand here is, so you have to understand the plane of the grafts. If you understand plane of the grafts, it is very easy. You can choose views very easily. So I'll just come back to this surgical picture. So you see the left-sided grafts, right? So normal, if you look at normal, plane of left anterior descending artery, so it is the septal plane. But when it comes to venous grafts, so if you see the venous graft, it just goes across the septum. So the plane is not septum. So it is almost around 45 degrees to the septum. So, and if you see, draw a line on this venous graft, right? So if you draw a line, and that is almost the plane, right? So the perpendicular view to this plane is basically RAO-caudal, right? So if it is a graft to left circumflex branches, the perpendicular view becomes a RAO-caudal. So I hope everyone is understanding this. So this is the best view, and I'll show the best views in CT as well as in conventional angiogram. So coming to the course of venous graft to OM, so the best view to visualize venous graft is, it's a RAO-caudal, because the plane of this venous graft is something like, it's something like this. So it is located like this. Sorry, I mean, I'm visible in invert endo. You have to put my picture. So it is located like this. So, and exactly perpendicular plane comes in RAO-caudal, either RAO-caudal or elevocranial. But elevocranial is not ideal because the distal part of the graft is, it goes directly downwards. So it becomes an end-phase view. So RAO-caudal is the best view. You can see here. So this is the CT angio. So, it's a transparent view of CT angio. So where venous graft to your OM is quite visible. So completely visible on entire course from proximal anastomosis to distal anastomosis. And you can see this is RAO-caudal. You can see RAF in your right lower corner. And this is a RAO-caudal view. So you can see how, clear it is visible. And this both CT angio as well as angiogram are of same patient. You can almost compare. So they are in the same view. Yeah. So and okay. Oh yeah, yeah. So coming to a course of right venous graft. So right venous graft course, and this is as I already discussed, right venous anastomosis. Okay, thank you. Yeah, right venous anastomosis, venous graft anastomosis, and the course of right venous graft. So both are almost similar to the course of right coronary artery. It's not completely similar, but more or less the course is similar. So if you see this, this is the right venous graft, and you can visualize it best. The view that visualizes right coronary artery, that is LAO view. Simple LAO view, or so you can take some caudal, LAO-caudal. If you want an exact perpendicular view, it is the LAO-caudal. Plain LAO is also sufficient to view the complete course of venous graft. See, you can see this is the right venous graft. so which is well visible in LAO. Again, it is because the course is almost similar to right coronary artery. So now I'll come to the distal anastomosis. So I completed proximal anastomosis and course of the grafts. I'll come to the distal anastomosis of the grafts. So this is again one important thing, which you have to visualize because most often, so the early post-op ischemias around 3 months, where patient presents after 1 month, most commonly around 3 to 6 months. So in those patients, the most common problem which I encountered is the distal anastomotic stenosis. So the distal anastomotic stenosis constitutes major reason for early ischemias around 3 months. Okay, so yeah, to identify or to know the view in which you can visualize distal anastomosis very well. So if you have a CT angio of patient, you can in fact read it beforehand. See, you see this patient CT angio where, so I went into, LAO caudal. You can understand here ALF, F is foot, L is left, A is anterior. Left anterior, foot means caudal. So in LAO caudal, so I am able to see the distal anastomosis of the venous graft separately from the right coronary artery. I hope you are all able to make it out. So, and this is the ideal view. So most often, right venous grafts, you can clearly see in LAO view, distal anastomosis, or with LAO caudal views, or sometimes, you may have to take some LAO cranial views. See, this distal anastomosis is a very tricky thing. You can't apply a common rule to visualize distal anastomosis, because many times we see after graft is applied. So, yeah, someone raised hand, Harikiran.
Sir,
you raised your hand.
Sir, sorry to interrupt you, sir. In the CT angiogram, is it the anastomosis at the like in the middle of the artery? Is it anastomosing with the native artery, or is it at the junction of the myocardium to the vessel, sir? Because here it seems there is some gap between the anastomotic site and the myocardium.
No, it's a reconstruction. See, it's only a reconstructed film. See, to make it clear to you, we removed some part of the tissue there.
Okay, sir. Thank you, sir.
So we removed some tissue to understand. And it is in the distal RCA anastomosis.
Okay,
because
thank you,
I came to, it's almost LAO caudal view. So it appears like this. In LAO caudal, even the distal RCA appears as a mid RCA, right?
Oh,
so, okay. It is a distal RCA anastomosis, and clearly it is separating from the native RCA. So this distal anastomosis, I mean, in my opinion or in my practice, there is nothing like a standard view. You have to find a view for the respective patients. Yeah. So now I come to left internal mammary artery. So far we discussed, venous grafts, left venous grafts, right venous grafts, proximal anastomosis and course of the venous grafts and distal anastomosis. I'll come to lima now. See, to understand lima, so the first thing, I used to think lima originates from inferior aspect of subclavian artery. That was my understanding from my UC time. So, but origin of the lima is not from the inferior aspect. So now I am showing a sagittal plane of CT. So you can see this sagittal plane of CT. This is anteroposterior section of the body. I hope all are able to see. So this is a subclavian artery, right? And so there are two branches coming out of subclavian artery. I hope you are able to see the arrow. Harikiran.
Yes, sir.
Yeah. So this is the subclavian artery. So this is the subclavian artery, and there are two branches coming out of it anteriorly. So the lower one is basically internal mammary artery. The upper one is thyrocervical trunk. So, and I'll show you the film. So yeah, I think this film. So you can see this is an anteroposterior section. Anteroposterior section. So I'm just coming from right to left. So this is ascending aorta, innominate artery. This is the arch, and this is subclavian, right? And you see the subclavian. You just follow the subclavian. I'm following subclavian. Two branches came, right? That is the first is the vertebral artery, and next is I think that thyroacromial branch. And now you can see. So this is the lemma. So left internal mammary comes from anterior aspect of the subclavian artery. So this is a very, very important point which we have to understand to cannulate left internal mammary artery. Yeah. So, and coming to the course of the lemma. So I'll go to cannulation subsequently, as for all grafts. So coming to the course of the lemma, it is plain, so on anterior part of the heart. So most often, the perpendicular view is a plain AP view or a simple epicranial view is enough to see the complete course of the lemma, either plain AP or simple epicranial. And coming to the distal anastomosis, so you can see in this CT angio. So distal anastomosis of lemma is best visible in lateral view. So always, lateral view is mandatory. You can see in this CT image where, so in fact, the limb, your LAD is lifted up. So lifted up because of your graft. So, and you can clearly see the graft anastomosis. And in the same patient, this is a distal anastomosis. So best view for distal anastomosis is the lateral view. So which always we have to take analyzing lemma. Yeah. Now I'll come to the cannulation of these grafts. So now we understood the proximal anastomosis and its relation with the native vessels, and also course of the grafts and its relation to the planes of original native vessels, that is atrioventricular plane and septal plane, and distal anastomosis. So now we'll try to I'll try to discuss on cannulation of the grafts. So the basic understanding which we need is the view in which we have to cannulate left venous grafts. As I already discussed, for simple left system, it is a native left system. So we all know LAO works well because so that LAO on two extremes of aorta in LAO, you see both vessels. On left extreme, you see left system. On right extreme, you see right system. So this is the exact representative. That is cross section of transverse plane of CT angio where I'm showing you the left plane. But when it comes to graft, left venous graft, so it is exactly in the middle of your LAO. So that is the reason many times LAO view won't work for cannulation of left venous graft, at least in my experience. But if you want an LAO, so you have to take an extreme LAO. So that means you have to take more than 60 degrees or 70, 80 degrees. Either take extreme LAO or just come to an RAO view. So you can see the first picture. This is the RAO view where you can clearly see your left venous graft on the anterior in the anterior aspect. In the anterior aspect. So now I'll show. So when you are cannulating left venous graft, so always my practice is I'll come to an RAO view. So this is the RAO view. Hope you are all able to see. And with the JR, either JR4 or your regular JR 3.5. So probably JR4 is preferable because the length of the primary curve is a bit more. So take a JR4 and come to RAO view, turn the tip anteriorly, so which you can understand, with this CT picture, because it is very located in the anterior aspect of aorta. So my tip is anterior. Now what I am doing, I'll just pull the catheter back. Just see. I pulled catheter back and catheter it jumps and sits into the venous graft. So I'm pulling the catheter back, it jumps and sits into the venous graft. So that is the venous graft. So wherever it hooks, so most likely that is a graft, right? So, and here, I'll just show you. So this is where I hooked. And this is, I injected where I hooked. Hope you are able to appreciate. So after hooking, I just injected, this is a graft and this is a graft to OM, right? So, and here what we have to understand is the location of venous grafts. Say for this patient, there is only one venous graft to left side, that is SVG graft to OM. So that's why it is very easy. So it just hooked and it is OM, which already I know. But if there are 3-4 grafts, so then what you have to do is whatever maneuver which you are doing. So once the first graft is hooked, you pull the catheter back, little back, right? And then while rotating counterclockwise, you pull it back. So what you have to understand here is every next graft, so once your first graft is hooked, every next graft is cranial as well as bit left to the lowest graft. So that's the reason while pulling, you always rotate counterclockwise so that it goes cranial as well as left to hook your next left grafts. So, and always we can do in a RAO view. So this is the best view in which you can cannulate. So even if you have multiple grafts. So, and for best catheters for cannulation of these left grafts is JR. Most often it works, and left venous bypass in cases where it won't work. So you can take a left venous bypass. But when you are doing procedures and where you think you need a good backup, because this JR and left venous bypass, they sit pretty well into the venous graft, but they won't give you backup support. So wherever you need a good backup support, so you have to use either hockey stick catheter or you can even use AL. And whether it is hockey stick or AL, so the best view in which you have to cannulate, in my opinion, is RAO view. So in RAO view, you can cannulate it pretty easily. And coming to the right venous grafts, as already I discussed, you can see the relation of native RCA to right venous graft. So both can be well visible in a LAO view. So this yellow line indicates the LAO view. See LAO view, how LAO view depicts or transects your aorta. So your venous graft and RCA are exactly on the right end of transaction. So that's why LA view works for cannulation of right venous graft. And coming to the catheter, so you can see this is a right JR. So in my opinion, so see when it comes to JR, so because we have a practice of gas sterilized catheters, so most often the gas sterilized catheter, the primary curve is straightened. In a new catheter, primary curve is very acute. So because the primary curve is very acute, so new catheters, they won't cannulate coaxially to the right coronary artery. As already I discussed, the venous graft to right coronary artery, it goes, the course, proximal course of this venous graft, RCA venous graft is straight downward. So that's the reason, so majority times, see this is RCA, it is nearly at the origin of venous graft, but when I am injecting, contrast is not completely going into it because it is not coaxial. It is just hitting the lateral wall of venous graft and all my contrast is bouncing back into the aorta. You can observe it. And in such a situations where your JR won't work, so where the graft is going downwards, so you can use either Ampliger right, so which is again a good catheter, or my usual catheter is MPA. I always use MPA. If JR won't work, I'll use an MPA. So this is an MPA catheter which typically faces downward and it just goes into your graft. So MPA catheter works. So overall, so if your right venous grafts are on outer curvature of the aorta, so that means that's a usual right anterior and location or right lateral location. So this is a location. If they are on this location, your JR, MPA and AR, MPA, this catheter, most often it goes, it happens with JR. If not JR, MPA will definitely hook your SVG to RCA. But I have good experience where venous graft is located posteriorly. See, normally right venous graft is located right anterior or right lateral. But sometimes surgeons may give, see when they go up, so they may give posteriorly in this part of the aorta. So if they go posteriorly, then to understand it, I'll just come back and I'll show you. See, you can see this is a venous graft location on aorta, that is right anterior. Posterior means almost in this plane. So yeah, if it goes to, posteriorly, posterior. So I mean, this is very difficult. So cannulating posteriorly located right venous grafts is very, very difficult. So, but most often, AL may work. So AL is a right catheter. All these JR, MPA, AR, they won't work in posteriorly located right venous grafts. And coming to the cannulation of Lima. So Lima, see usual catheter I use. See in cannulating Lima, so there are two things. First we have to cannulate subclavian artery and next we have to cannulate Lima. So for cannulating subclavian artery, so always JR, we have to use JR. So keep your JR in arch of the aorta and rotate it anti-clockwise and then push it inside. So not clockwise. So it is always anti-clockwise. So keep your catheter in arch, rotate anti-clockwise, and usually either it goes to left common carotid or left subclavian. So once you enter subclavian, the immediate thing which you have to do is you have to compare the pressures in aorta to your pressures in the left subclavian. So when you are doing Lima angiography, so always you have to see the pressures, aorta pressures versus subclavian pressures, because sometimes because of subclavian stenosis, there can be a coronary stele which causes angina. So which you may miss if you don't see this, pressure difference. So always see and appreciate the pressure difference, and then send your thermo wire down the subclavian and push your JR down the subclavian and take out your thermo, and next comes what you have to do. See, once your catheter gone, so you can see this is the catheter which is gone into left subclavian. So once you entered, see, all this stuff we'll do in plain AP. So plain AP. So entering subclavian is in LAO view. Entering subclavian is in LAO view. And once you enter subclavian, come to AP and go further into subclavian artery. And once you have gone further, take out your thermo wire and now come to right anterior oblique view. So now this is the right anterior oblique view. You can see I'm just injecting in right anterior oblique view. Okay. So why right anterior oblique? Already I showed you, as a preamble to this presentation, I showed origin of lima. So lima originates from anterior aspect of the subclavian artery, right? So to see whether your catheter is facing anteriorly or not, RAO view is, the best view. But literature describes either RAO 45 degrees or a steep LAO view, like 70 degrees or 80 degrees of LAO view. Either will work, but I commonly use RAO view. Predominantly. So I use only RAO view, and I'm successful in almost all the cases in RAO view. So take RAO view. So now I'll show in RAO view. You see the tip of the catheter. What is happening to tip of the catheter? Are you able to see? See, tip is coming more and more anterior. So my catheter is in this position when I injected non-selectively, and then I have not done anything. See, my catheter position is there, but I am just turning catheter anti-clock so that it faces anteriorly. So which I can appreciate. See, whether it is turning anteriorly or it is going posteriorly, I can well appreciate in RAO view. Hope you are all able to see. Only observe the tip of the catheter. Right? So catheter is coming anteriorly and it just hooked lima. So this is the best technique to hook lima. But sometimes, wherever there is a tortuosity in subclavian artery, or sometimes because of origin of subclavian like type 2 or type 3 arches, it becomes difficult to engage. In those cases, so what we can do, we can take a non-selective angiogram with the catheter in subclavian origin and with a BP cuff on left arm, wherein pressure raised above the 20 mmHg above the systolic pressure of the patient, so that you are occluding flow downstream, and you are trying to more and more contrast will try to enter into your internal mammary artery. That is one technique. So another technique which we can use is send a PTCA wire with a good loop. So and send that wire into your lima, internal mammary artery. So once the wire is gone in, so then you can push your catheter over the wire into lima. So this is another technique which we can use. So there is one more technique commonly which is used for rima, that is putting a pigtail and pulling the pigtail back. So pigtail is like more angulated. See, when you unfold the tip of the pigtail, somebody activated their pencil. Kindly deactivate. So when you unloop pigtail, so it becomes very acute. The tip has very acute angle. So just go down the subclavian across the lima, internal mammary artery, and slowly pull it back so that unloops and then the tip falls into lima. And then you put a PTCA wire and then you remove your pigtail, and then you put your routine diagnostic catheter and do your angiogram. But this is a bit traumatic, thing. So analysis of So now we learned about anatomy, and we cannulated all the grafts, and now we have to analyze angiography. So analyzing angiography in a post bypass patient is very, very important. So, and at the beginning, see, we had a question. So, is it a CT angiography or conventional angiography? See, if I have a patient with whom there are no details of grafts, hi Shashi, with whom there are no details of graft, so obviously I'll prefer to do a CT angiography. So, but if I have all the details of grafts and with documented ischemia for a patient, I prefer to do a conventional angio. So if there is no detail available on grafts, I would prefer to do a CT angiography, not conventional. If I have all the details, I'll just go with the conventional angiography. But sometimes even after conventional angiography, we may not be able to some grafts, and we may end up in a CT angio again. So, and sequence of angiography in these patients. So normally what I do is, see, first I'll do a native left system, right? And then go to native right system, followed by right venous grafts, left venous grafts, and then lima. So this sequence, so the sequence is important only to minimize your number of catheter exchanges. So you can minimize your number of catheter exchanges with this sequence. But if your JR doesn't work, then you may have to change sequence, and you have to do it. So, but this is a normal sequence which you can use most of the times. And coming to the analysis of angiography. Now, I would like to show a few angiograms, and and then we'll try to discuss on these angiograms. So you can see this is a native left angiography in a patient, post CABG patient, and you see this again in another patient. So here, see the basic difference at which I want to show. See in this, the first cine, the first image, so your LAD is totally occluded. There is no flow downstream into LAD. And in this case, LAD is, there is a flow downstream, right? So now I'll show both these cases with their graft injection. So, and before going to that, so I just want to ask you, all of you, so what is the difference? So in one, your distal LAD is not visible. In another, your distal LAD is visible. Can it give a conclusion on the graft of this patient? So this is where, we should observe the competitive flow into the native vessel very carefully. So if you see, because this is a CTO, this is a total occlusion, there is no antegrade flow into LAD, I can't see competitive flow. So in this case, I can't comment whether lima is patent or not, or the graft to LAD is patent or not. I cannot comment because there is no antegrade flow into LAD. But if you see this, where there is a good flow into LAD, and I'll show the cranial views of these two patients. Yeah, these are the cranial views. You can see the cranial views. See the cranial views. Try and appreciate. So if you see the cranial view of first patient, there is no antegrade flow at all. So most likely this is a total occlusion of LAD, right? So I cannot come to any conclusion on lima in this patient where there is a total occlusion. But if you see this patient where there is a good antegrade flow, and you can also, and you can also see good flow into the distal LAD. Hope all are able to appreciate. There is a good flow into distal LAD, and there is no competitive flow at all. So competitive flow, we can, and if you keenly observe the distal LAD, so you can understand competitive flow. That is, when you are giving contrast, so sometimes you see contrast, sometimes you see, no contrast. Half of the vessel is visible, half of the vessel is not visible because of the competitive flow. So when there is no competitive flow, you can see complete vessel clearly, distally. So in this case, there is no competitive flow at all in distal LAD. So this says my lima is gone. So even if you try and look for lima, most often you don't see any flow through the lima. So observing competitive flow in native vessels is very, very important. I'll show you one case where the patient's records misguided me, but my angiographic analysis and CT angiography comparison guided me properly in taking decision. So I'll show the lima injections of these both angiograms. Yeah, the first one where there was CTO and wherein I can't interpret what is going downstream. So this is a lima. So there is a good flow, right? And the second case where there is a good flow into the LAD without any competitive flow visibility, you see the lima. This is the lima. So it is, string sign lima. So lima is completely occluded. So this is what exactly, see, with native vessel injections, we can understand how the graft is for that vessel, provided you can see the distal territory of native vessels. And you can see this is a right angiography. You see the right coronary artery again. So if you see these right coronary arteries totally occluded, see we are not able to see any distal territory, and see this artery. Hope you are all able to appreciate. So though it is a non-selective injection, there is a good contrast flow into the RCA. But if you clearly see, PDA is not visible or very faintly visible. Very faintly visible. So this again says for this patient, the PDA is very faintly visible because there is a competitive flow. This says there could be a patent venous graft for this patient. And in the first case, I don't know, it can be patent, it may not be patent. But I'll show you both the cases, venous grafts. So this is the first case where there was a total occlusion. I don't understand how the venous graft is unless I inject into it. And you can see the venous graft. It is quite good. So that's what in most of the patients happen. Once you give a venous graft, there will be accelerated atherosclerosis of native vessel, and that goes to total occlusion. And you see the second patient where native vessel angiogram, so there is a faint visibility of PDA with a competitive flow. I don't know whether you are able to appreciate it. And now I'm showing the venous graft of that patient. Can you see? So venous graft is attached to PDA, and PDA is completely filled through the venous graft. And this PDA, this venous graft filling is not going into PLs. That also you can appreciate. So here, PL is predominantly filled from your native RCA, and PDA is predominantly filled through venous graft. So that's how, that's the reason in native injection, I'm not able to see any competitive flow, but there is a good competitive flow into PDA because predominantly the venous graft is connected to PDA. Yeah. So I'll show you another angiogram. I think this question was raised by our Anand in the beginning of our discussion. So this is a patient post CABG, came with class 3 angina. He had a Lima to LAD and SVG to OM and SVG to RCA. So, and with this, and patient had a CT angio outside and he came with CT angio. I'll just show you conventional angio and try to analyze. So this is a native left injection. So it was mentioned there is a venous graft to OM. You can see this is a native vessel angiogram. So there is a tight lesion in LCX and LCX and the OM is the OM1. And in fact, this is the LAD and which is giving diagonal, right? And this is the OM1 and OM1 is completely filling from LCX. I'm not able to see any competitive flow in OM. So this is one thing, which you have to observe. So there is no competitive flow into OM. And my second OM is filling from the first OM, right? So we can also see, but at the first look, I couldn't make out any competitive flow even into the diagonal. But if you see carefully, all of you observe diagonal. See, now the diagonal is filled, completely filled, but still I am injecting. Even though I am injecting, if you see the contrast in diagonal, flushing towards LM. So the contrast is coming back towards your catheter. So that is nothing but a competitive flow. You can observe. So with this, see, initially I couldn't make out that competitive flow because it is very faint. So, and this, there is no graft to OM. So I went into a confusion while doing angiography because it was mentioned there is a graft to OM, but I'm not able to see any competitive flow to OM, and I'm not able to see any graft, despite almost half an hour of scrutiny inside the aorta. So then again I analyzed the angiogram. Then I could make out this competitive flow in diagonal. So now I will show the injection into that venous graft into diagonal. So can you see? So when I am injecting through the native left system, so all this diagonal is getting filled up to this venous graft, and there is a competitive flow. Because of competitive flow, it is flushing backwards, towards my catheter. So that's what exactly happened. So here the venous graft is to diagonal, not to the OM, because that is very, very important point. If it is to the OM, there is no point in doing anything to that OM. And this is Lima of the same patient. So, and this is the right right native vessel. So, which is again totally occluded, and distal vessel is filling through the collaterals. Yeah. So on table itself, because of confusion of whether the venous graft is to the diagonal or OM. So I saw the CT angio again. So in CT angio, I could make out. So I mean, it is worth learning how to see CT angiograms, especially these kind of patient. It helps a lot. Now I'll show you. This is ascending aorta, and whatever the first graft which comes is basically the left graft. Sorry. So the first graft, yeah, I'll just pull it. See, the first graft is left-sided graft. So this is the first graft. So first thing what I should know, are there two grafts to left system or one graft? So I'll just further come down. So this is the, sorry. Yeah, this is the first graft, right? And there is one graft coming to right and another one graft coming to left. There are no more grafts, okay? And native vessels came. So there are only 2 grafts on aorta, and one to left, one to right. So I made, see, it's only one graft. Now I'm following this graft distally. You just follow that graft distally where it is going. So you can see clearly it is going and attaching to diagonal. So not native, LCX. So native LCX is far away. So then I understood, the graft is given to only LAD, and retrospectively I made out there is a competitive flow. In first view, I couldn't make out the competitive flow. So, and this is C. And it's a good practice, always to draw your grafts and native vessels to completely understand, what you have to do to this patient. See, in this case, if I go with his, operator's notes, so he wrote as a venous graft to OM. So then I would have ended up in a problem. I would have left OM and, come out. So, but actually that graft is to the diagonal. So now obviously I have to treat OM. So we treated LCX, OM, a bifurcation stunting, and as well as RCA. So yeah, that's the difference which comes, in this kind of patients. Next, in analyzing angiography. So these kind of lemas. So this is known as a string sign, which commonly happens in a patient where the LAD lesion was not significant. See, for lema, the lesion in LAD is very, very important. If the lesion is not that significant, so most often these arterial grafts will close, but venous grafts can work despite lesser lesion, but arterial grafts usually gets occluded. And this is a typical example, the CT angiogram which we have done in last 1 week. So wherein the lema is completely stringed out, and if you see the native LAD is, there is a lesion, but there is only 40 to 50% lesion. So most often those kind of lemas, so says it is insignificant lesion at this time of CABG. That's why it became a string over a period of time, and subsequently LAD got occluded. So once you analyze angiography in detail, and most important thing is the competitive flow to understand grafts, then we have to take decisions. So while taking decisions in these patients, so there are many factors which influence. The anatomic factors which influence your revascularization strategy in these patients. And there are factors, which favor angioplasty. There are factors which favor bypass surgery. So factors which favor percutaneous intervention. The most important thing is patent graft to LAD. So whenever there is a patent graft to LAD, so in all those patients, it is worth considering percutaneous intervention. So if the LAD graft is also occluded along with other vessels, then probably, we may orient towards redo bypass. And 1, 2, 3 culprit lesions. Yeah, this is, again, it's a vague thing. And other is inadequate conduit. See, if the patient, both SVGs and, radials are already, used in previous bypass surgery, then there is no conduit. So in those cases, again, PCI becomes the first option. And it's a normal LV function. And difficult surgical access, especially this happens, wherever there is a mediastinal scarring secondary to radiation or infection, or sometimes, post-surgical pericarditis. In those situations, your surgical access becomes very difficult. And also, if there are branches in posterolateral target vessels, if the branches are posterolateral, so a redo bypass becomes very difficult. So again, in those areas, you can consider, PCI. And prior muscle if a patient had unhealed sternotomy in first surgery, wherein sternotomy is closed by muscle transfer. So in all such patients, it's not advisable to open sternum again. So it is preferable to go to percutaneous intervention. And in patients where you are anticipating another surgery in future, like patients had valve lesions, like mild to moderate AS, or some mitral valve disease, or patients already having a prosthetic valve, maybe bioprosthetic valve, so who can go again for restenosis and reintervention or resurgeries in future. But in those patients, it's always wise to consider percutaneous interventions in view of future surgery. And some factors which favor bypass surgeries. Most important thing is your LAD scenario. The LAD graft is occluded along with other vessel lesion, multi-vessel disease. Then obviously bypass surgery becomes a good choice. And also in patients with the ejection fraction less than 35% and multi-vessel disease. And multiple SVG lesions and degenerated SVG grafts, and if there are good available conduits. So in those situations, probably bypass surgery will definitely holds a good option. So next thing, the question which comes, if you decide about percutaneous intervention in these patients, is it the native vessel PCI or graft PCI which you want to do? So again, this depends on how bad your venous graft is and the age of the venous graft. I'll just show you, one case, the case which I have shown before. So this is the native RCA. I don't know whether you are able to appreciate. So it is diffusely diseased from the ostium. In fact, my 5 French catheter is not entering into ostium because of the tight lesion there. So there is a diffuse lesion from the ostium and also mid RCA. And there is a tight lesion in the distal RCA, right? So this is the native RCA scenario, and you can see the venous graft. So there is a lesion in the proximal area and also one more lesion here. So there is a venous graft lesion, but this venous graft is almost 12-year-old. So in such a case scenarios, see, whenever venous graft is beyond 10 years old, so it's not wise to touch a venous graft. So especially if you see a diffuse disease in angiography, it is not wise to touch venous graft because the embolization, no flow chances are very high in these kind of venous grafts. But if you see in this particular patient, the native vessel. And another difference between venous graft to native vessel stunting, the patency rates of native vessels are better than the venous grafts. So wherever your PCF native vessel is simple, it is always better to do a native vessel PCI. But in this case, so it is a very calcified lesion. I don't know whether you are able to appreciate. So you can see the vessel even without contrast. I think you can see. So the mobile calcium. So it is very calcified and the long lesions. I don't know how many stents he needs minimum. So he needs a rotablation, IVAS, rotablation, and minimum 2 stents, maybe 3 for RCA. So that's a situation in RCA, and this is a situation discrete lesions. Though there is some blocking in between in venous graft. So this is a tough situation to decide, but in view of rotablation, cost of the procedure. So after discussing with patient, see, simply rotablation will increase my cost by another 1 lakh. So because of the cost of the procedure, we thought, and also the discrete lesions in the venous grafts made me look towards venous graft intervention. But I decided to do an IVAS, while doing intervention. So I did an IVAS for this guy. So there was only blocking, there is no diffuse blocking. So blocking is present only discretely in this area as well as this area. So then, while after seeing, that IVUS, we decided to, treat venous graft. We treated venous graft with 2 stents. You can see this is after treatment. You can see the filter in the venous graft. So we kept a filter. It's a spider filter, and then we stunted, and you can see the result. So this is the final result of this venous graft. So, and you can also appreciate, before there was no flow into the PL, but now even PL is filling from the venous graft. So when you have both native vessel and venous grafts, so always you have to weigh the benefits and problems of intervening grafts native vessel, and also take cost factor, and based on that you try to optimize treatment to your patient. But in general, venous grafts, beyond a decade, so they are not ideal for intervention. So, but at times I use these venous grafts for a retrograde as a retrograde conduit. So, in patient where there is a total occlusion of RCA, I have one case. So, where there is a RCA total occlusion as well as venous graft complete occlusion. So, we can use this venous graft as a conduit for retrograde. But when we are using as a conduit, so we send only wire and microcatheter. So never dilate venous graft. If we dilate venous graft, you will end up in no flow or no reflow. So we can use it as a conduit and do your native vessel angioplasty. I think this is the first injection before procedure, and this is the injection, after procedure. Thank you. Yeah, now we'll go to if there are any questions and and clarifications, we'll try to discuss. Now it is open for discussion. So you can unmute yourself and discuss. Nag.
Yeah, nice actually. I really enjoyed the presentation. The take-home points is really to understand where the graft vessels are arising from, and how to understand how they are different from the native coronaries. So that from next time probably I will think of only selective angiogram even for the graft instead of going for a pigtail like aortic root angio.
Last 5 years, I never did a non-selective angiogram.
That's great. That's great. We'll try to do that. Very good presentation, in fact.
Yeah. So, any questions, Shashi, or any additions?
Your analysis of the ROO or better visibility. The way you have shown how the views will look like, the graphs, the left graph, right graph, that's also good.
Yeah. Shashi?
I actually caught it joined in between. I missed the competitive flow part.
You missed a major part of anatomy.
Yeah, that's right.
Yeah.
But
I gave emphasis on anatomy, understanding location, understanding the ideal view for grafts, all that stuff. But you can add some points, whatever you would like to. Or any questions? Anand.
Sir.
Anand, you asked one question in the beginning. Have you got the answer?
Yes, sir. Yes, sir.
You said, you find it difficult to cannulate grafts. That is one difficulty which you.
Yes, sir. Now I understand much
Another
better.
thing is how to identify, whether the venous graft is to the diagonal or to the OM.
Yes, sir. Yes, sir. Now I'm better. I have a better understanding, much better understanding. And this
Yeah.
RA
See,
for
in
engaging
analyzing angiogram, competitive flow is the most important thing you shouldn't neglect. That gives you, lot of insight into the entire anatomy.
Yes, sir.
And where exactly your graft is connected.
Yes, sir. So there is one doubt, sir. In venous grafts,
keep your mic close.
Sir, yes, sir. Sir, in venous grafts, there are fibrous lesions and there are atheromatous lesions. So
Yes,
how do we
exactly.
differentiate, sir? One thing, one it cannot
Yeah,
lead to
it's
balloon,
all
the other
basically based on the age of the lesion. So most commonly these fibrous lesions happen in first 1 year.
Okay.
If you have a patient who came back with symptoms within 1 year after a SVG, and if the lesion is very discrete, and if it is at the ostium, it is most likely it is a fibrous intimal hyperplasia. So these lesions, they are very hard to yield to your balloons. But if you have a patient who underwent CABG, few years back or a decade back, right? I think more than 3 to 5 years or more than 10 years. So in those patients, it is most likely atheromatous degeneration. So it is atheromatous degeneration. So it is basically, the duration of surgery, right? And also the discreteness of lesion. So, and this fibrous intimal hyperplasia is very discrete lesion. Unlike atheromatous degeneration is a very diffuse lesion.
Okay. Okay, sir. Thank you.
I would like to ask one thing.
Yeah, Shashi.
Yeah. Post CABG presenting as acute MIs. Any special precautions? Total.
Yeah, it's a good question. So in a post CABG patient, always say, for example, patient had we'll take a case example. Patient had a right venous bypass before, right? And which is a dominant artery, a dominant artery, and came with an inferior wall MI now.
Yeah.
Came with an inferior wall MI now. So this is a very tricky situation. So always you have to analyze the culprit vessel before you enter into cath lab or before you take patient into cath lab, right? So in this case, had a right venous bypass and came with a right inferior wall MI. So it's most likely, and if you have previous angiogram, it is always advisable to analyze. Since the previous angiogram, the RCA is showing some discrete lesion or stuff like that, then you should go with a plan to treat native vessel, right? So it's once you do angiogram, again you will analyze where exactly is the problem. See, for example, venous graft is totally occluded.
Yeah.
So that is a thrombus, right? And your native vessel is flowing a bit, maybe some 95% lesions like that. Then you treat only native vessel, not venous graft, right? But in other way around, if your native vessel is a total occlusion, chronic total occlusion, right? If it appears as a chronic total occlusion, then most likely the acute event is because of your venous graft occlusion. So in that case, you have to decide based on your comfort, how to intervene this venous graft, because in venous graft interventions in such a scenario, you will tend to create no flows.
Yeah.
Right? It is always
more likely to result in a lot of no flow and
no flow. And see, if, for example, if patient had a retrograde flow from left system or from Lima, if you tend to do something to right venous graft, so you will create a no flow, and even that retrograde flow will go off, and patient will end up in a evalved MI. So we have to take decision very cautiously, and it is always advisable to use protection devices and also thrombolytic agents in the either intra-graft.
Yeah. Do you advise intracoronary thrombolysis in that setting?
Yeah. I mean, you have to consider. You have to keep all options open.
Okay.
You have to keep all options open.
Yeah, intracoronary thrombolysis at what dose?
It's general dose is what we use for intracoronary. Yeah, you can use tenecteplase, or you can use even altiplase. I have not done any time, but I think there is some dose based on weight.
Yeah,
probably
half the dose is suggested thing, but not proven.
Which you have to give again. See, you need a perfusion, either perfusion catheter. Mostly, you have to give it with a perfusion balloon.
Yeah.
So you get a good perfusion balloon available from Atrium, but I think it's not there now. So, or you can simply take a microcatheter and
microcatheter.
You put multiple holes on microcatheter and then use that microcatheter to inject. So microcatheter is a good choice if you don't have a perfusion balloon.
Sir, I have one more question, sir.
Yeah, Anand.
Sir, sometimes we see that the graft fills retrogradely to a certain extent through the native coronary.
Yeah.
So it means the native coronary is also patent, and the graft is also patent.
See, Anand, it's very simple. Yeah, it's very simple. See, if the graft is filling, right, retrograde, most often the graft is totally occluded. Right? See, again, what you have to understand here is the competitive flow. Understand? If the graft is really patent, right? If the graft is really patent, so there should be some competitive flow in the distal graft. But as per as my experience, wherever I have seen a flow into graft from native vessel injection, those grafts are totally occluded grafts.
Yes.
So in such scenarios, most often I'll try for 5-10 minutes to inject into that graft. If I don't get also, I'll come out. I don't try too much to cannulate those kind of grafts. But if you look into that graft flow, if there is no sign of competitive flow, that says the graft is totally occluded.
Yes, sir. And this thing I experienced this in a patient with a left coronary injection. The Lima was filling, the lower 1/3 was filling retrogradely, but inside the Lima there was competitive flow. Inside the Lima there was competitive flow, but it was filling kind of retrogradely. There was left main disease with osteal LAD, some tight lesion was there, but the Lima was patent with some competitive flow inside the Lima. It was filling retrogradely. We could not engage the subclavian through the femoral. Totally, no idea where the femoral was. Even aortic root angiogram was done. The subclavian could not be, left subclavian could not be visualized. Finally, we went through the left arm. Through left arm, it was found that the subclavian was totally occluded.
So,
It was an exception, rare one of the things. So finally, what was done was.
See, that is the reason you are seeing, competitive flow. See, if lima is patent and subclavian is patent, and you have a tight lesion in LAD, right? In that scenario, you don't see any competitive flow into lima. Understand? Your native vessel injection never fills lima. It is going into lima means the pressure inside the lima is less. Either there is an occlusion in the lima or occlusion in the vessel feeding lima. That is nothing but coronary steel. I mean, that's subclavian total occlusion. See, that's the reason whenever you are injecting, I mean, while doing lima angiography, before you do angiography, the first step is when you entered subclavian, you try and appreciate the pressure difference between your aorta to subclavian. After that, you inject into lima. So many times we miss, subclavian osteal lesion.
Yes, sir.
So in that, see, what did you do? You treated subclavian or you treated LMCA to LAD?
LMCA to LAD stenting was done, sir. Finally.
Oh, is it?
Yes, sir. Yes, sir. So we did not open the subclavian. It was kind of calcified osteal part. Was calcified. A CT aortogram was also done. It was calcified. The vascular surgeon also said it will be very difficult procedure and risky. So we went ahead with left main.
So he had no symptoms in left hand.
No, sir. He didn't present with left arm symptoms. He presented with angina. Stable angina.
But is there any possibility of coronary steel even after stunting?
Yes, sir. That is what my question was. After revascularization from coronary, it may go to harm. I had this doubt, but he said.
Sir, I have a doubt here, sir. Sorry to interrupt, sir.
That is possible. Coronary steel is possible for this guy. But even subsequently, what happened in follow-up? Is asymptomatic or still symptomatic?
So, recently, sir, about 1 week, 10 days back, the procedure was done.
Okay.
Sir, in this case, hello?
But is that patient had even grafts to OM, LCX graft, something like that?
Yes, sir. Patient had a graft to OM and RCA also was there. RCA graft was diseased. RCA graft had a tight lesion. Actually, my question was that we should intervene the RCA graft, wait for some time, see whether his angina symptoms are improving, and then if necessary, we can go for lima. That was my original. I was thinking like that, but they said the lima is more important. That is the larger territory. So
if it is only angina, right? So and LAD is the bigger territory, right?
Yes,
so LAD is the bigger territory. And see, most often symptom relief in such patients you will see only when you treat LAD.
Yes, sir.
LAD flow. When you correct LAD flow, I don't say treat LAD. When you correct LAD flow.
Yes, sir.
And that correction of LAD flow, whether it is by correcting subclavian or LMCA to LAD, that is $1 million question.
Yes, sir.
So, I mean, you don't find any data on this, but I would prefer always to do a subclavian.
Yes, sir.
See, only thing in these patients while treating subclavian, I had one patient where we did. The only challenge is, always in a total occlusion, you should try to enter from retrograde. That is subclavian. You come through the left radial, pass the wire, and snare the wire in the aorta, and come out. If you try to go proximal to distal, if you create any dissection, you will close lima for forever.
Yes.
So that's not an ideal scenario. But it's lucky that this patient had a simple lesion in LMC LAD and you did it. But how he behaves in follow-up, you have to observe and you tell us in subsequent strategies meeting.
Okay, sir.
See the patient's symptoms subsequently, and you tell us because it makes us, wise.
Yes. Yes.
Sir, hello.
Yeah.
So in this case, if the stenosis were to be proximal to the origin of lima in subclavian, it should have been possible to cannulate it through the left radial approach. Sir.
Yeah, it is. Stenosis is only proximal to lima, but it is total occlusion and calcified lesion. That's
but
the
they
reason.
have tried through the left radial, no, sir. So when they have gone through the left radial, they would have cannulated the lima and do an angio of the lima.
They did it.
Lima was fully
Lima
patent.
Was patent. See, lima is patent, but the problem is the pressure in the lima is very less.
Yeah. Previously, they were saying that lima could not be visualized. That's why I got that out.
Now, what is happening here in left internal mammary? It's a kind of steel it created. It's not exactly steel. So, according to Annam, he said the competitive flow is seen in the middle of the lima.
Yeah.
So that means the pressure inside
is less than
pressure inside your coronary distal to LED lesion, and the pressure inside your lima is almost same.
Yes.
That's the reason there is a competitive flow there.
Yeah.
So in fact, if the pressure in and if there are no good collaterals to subclavian, see this subclavian has good collateralization, most likely from vertebral. Say, how is the vertebral, Anand, for that patient?
Vertebral was normal, sir. Only the ostial subclavian.
Because his left vertebral is intact, so he had a good flow. See, left vertebral and thyrocervical trunk gives a good collateralization to the subclavian. So when left vertebral is patent, in fact, if his left vertebral, just imagine a situation where left vertebral is coming directly from arch of aorta. It happens many times. That is a commonest anomaly you see. If in this case, left vertebral is coming from subclavian, coming from aorta, arch of aorta, this guy, subclavian artery would have filled from lima. When you inject into native artery, you can even see subclavian artery. That is a real steel. That is a real coronary steel. I mean, lima steel into subclavian. So in that situation, even if you do LMCA to LED stenting,
that will increase the steel.
That patient will come back with symptoms. So because his vertebral artery is still there on subclavian, most likely he may not come because the pressure is almost equivalent when there is LED stenosis.
Sir, how about treating
if there is no vertebral artery from subclavian, the lima becomes the major collateral for subclavian. So most of the flow will be stolen by your subclavian artery from LED. Yeah.
Sir, how do we treat, I mean, how do you approach distal anastomotic site lesions? Sir?
See, most often you see distal anastomotic lesion induced symptoms usually in first 1 year of post bypass surgery. But after that also can happen, but bit rare. So wherever you see a early distal anastomotic lesions, most of the data showed simple balloon dilatation is enough. POBA is enough. Just do a balloon angioplasty of distal anastomosis and leave it. That's all. That works pretty well.
Later.
And if at all a stenting is required, if there is discrepancy among the size of the distal and proximal vessels, which size do they generally take? So because
obviously the size is the distal size. Distal size. And try to end as close as the lesion. No, it's a very
should be
difficult. Yeah. So try to end as close as lesion. And lima is a very strange thing. I mean, if you want, I'll show you one case. Yeah. Okay, I'll show you one case. is there. Yeah, see this Lima. Are you able to see?
No, sir.
Yeah, let me share my screen again. Oh.
Yes, sir. We are to view the screen.
Not this case. Yeah. You are able to see?
Yes, sir.
See, this is the Lima injection. So this guy has, he came with post-CABG, I think almost 10-year-old, came with non-QMI, with severe LV dysfunction, decompensated LV failure, admitted, not able to stabilize with conservative strategy. Then, we opted, and we don't have any information on grafts also. So then I did CT angio first, and then we subsequently took him for intervention. See this is almost beyond 10 years. So there is a tight lesion at anastomosis. You're able to see? There is a lateral view. I don't know. I think I'll do one thing. All right. So this is all. Yeah. So what exactly happens in Lima? There is an entity known as accordion effect. Accordion effect. So Lima contains multiple loops, right? So venous grafts usually you won't see much loops, but left internal mammary artery you will see many loops in most of the patients. So what happened in this guy? So once I kept a stent. Yeah, this is post stenting. So I kept a stent. Yeah, this is the first one. You can see. See, can you see? Now the distal lesion is gone at the anastomosis. Can you see another lesion at the proximal end of the stent? Hope you are able to appreciate.
So we are not seeing.
Is it only on the image, sir? Just the plain image, or is it a?
It's a video, no? I'm playing video.
No, sir. Video is not being played on the screen.
Oh, I think it's not coming on screen sharing. What I have to do? Resume share. Okay. Or new share. Are you able to see now?
Yes, sir.
Yes.
Yeah.
Yes.
See, I kept a stent. Can you see at the proximal end of the stent?
Yeah, just proximal to the radiopex.
Yes. Okay. I gave NTZ, all the stuff, because Lima is notorious for, stenosis and all the stuff. I gave NTZ, diltiazem, everything. And, remember, this guy, this is the only vessel which is filling. Venous graft to RCA is gone, RCA total occlusion, and venous graft to LCX is gone, and LCX total occlusion. Only Lima is the only surviving vessel. That's why he's not able to recover. So, despite all vasodilators, we couldn't. That lesion has not gone. This is an accordion effect. So, because when you are stunting, when you stunt with a shorter stunt, not covering all the loops, the loop will shift proximally, and it gives a kind of concertina at the edge of the stunt. So then I kept a second stent. Yeah, are you able to see another window now?
Yes, sir.
Yes, sir.
This is after second stent. So, are you able to see?
Yes, sir.
Video.
More proximal to the radio.
Yeah, I kept a second stent, but the foolish thing which I did is I selected a short stent. Okay, so again the accordion shifted proximally. Right, the loop shifted proximally. Okay, and again I gave NTZ, diltiazem, all the stuff, but nothing worked. Then I went ahead and kept a third stent, and third stent is huge. I mean, I took a 28 millimeter stent, and which covers all the loops. So this is after third stent. Can you see? So this is what exactly happens in Lima, wherever, when you are stunting at the distal end of the Lima, where there are loops. So you should be very careful in choosing length of the stunt. Yeah, as you asked, width is also important, and length is also equally important if you find loops there. So that's the reason, all distal anastomotic lesions, balloon angioplasty is enough. This is not just anastomotic lesion. The lesion is extending down as well as proximally. There is an atheroma also there. So that's why we thought of, going ahead with stunting. But, because of the loops shifting and accordioning happened, and, that shows something like a lesion at the end of your stunt. Whenever that happens, your second stunt should cover all the loops. Never take a short stunt. And that's a learning point from this case for me. Yeah, I did it almost 6 months back. He's doing fine, and we are planning a retrograde angioplasty for RCA next month for this guy.
So is that looping due to inappropriately chosen length at the time of surgery, or does it happen even though they choose the appropriate length at the time of surgery?
And it is very difficult. See, loops, sometimes, a loop which is visible in one view disappears in the other view. Understand?
At the time of surgery, they will be visualizing it.
I mean, you mean when the loop is formed? Is that what you are asking? See, what happens
during the surgery?
Lima, so there is only a distal anastomosis, right? There is no proximal anastomosis.
Yes, sir.
Understood?
Native origin.
And whenever they take Lima, most of the times in venous grafts, what happens? They give distal anastomosis first, then they anastomose proximal, right? So when they anastomose proximal, they just measure the length and they cut it and they anastomose. So they won't leave much loop in the venous graft. But in Lima, there is a good amount of loop left. So that causes multiple loops most often. If the length is not chosen properly, your looping will be more. Loops are because of extra length of the Lima, which is
during surgery.
Yeah, during surgery. Okay.
Yes.
Sir, I have doubts, sir. This stent after placing proximally, there is
I have Dr. Krishna Prasad, our surgeon, with me. See, you can ask him. See, why we see, he is Dr. Krishna Prasad, our cardiac surgeon. He is supposed to join us, but because of their workshop today, because it is something related to grafts, I thought of inviting him. Because of his workshop, I couldn't invite. So they are asking why we see a lot of loops in Lima, not in venous grafts. I said, usually venous graft, you anastomose distally first and then you proximally, you try to cut it, the length.
Correct.
In Lima, you leave the length.
Correct. See, when we harvest the left internal mammary, we harvest the whole length. And we usually leave it a little bit long so that it forms like a contour along the lungs, because the lungs keep moving and they can sometimes make it tight. So we keep it more loose than the vein grafts. Whereas the vein grafts, because they are intrapericardial, they don't cross the pericardium and go into the pleura, they are intrapericardial. And as Sharath said, we first do the distal, and then measure it as accurately as possible to the proximal point. So the length will be, there will be less tortuosity. And also many surgeons, when they harvest the left internal mammary artery, what they do is they dissect it along with the fascia. So as we grow old, the vessel, like any other vessels, like radial, sometimes you would see it will become tortuous in aged people. So the tortuosity will be there in the natural anatomy itself, and it will be preserved in the proximal part and things like that, because the fascia is not divided. Sometimes some surgeons, they do it, what we call as skeletonized the mammary. In a skeletonized mammary, you will not see much of tortuosity.
Okay, what is meant by skeletonization?
Skeletonizing mammary is that we only harvest the mammary, leave alone all the fascia, vena comittantis and all those things. So only mammary as a single vessel is harvested. So it straightens out. And the idea behind skeletonizing is that because the flow in mammary is dependent on the amount of the runoff. So the more the runoff, more the flow in the mammary, and the size of the mammary increases. One of the concepts is, if the fascia is there, maybe the fascia might restrict the growth of size of mammary. Because nowadays we do total arterial grafting, and we do Y grafts. So we attach either radial or right internal mammary to the left internal mammary. That increases the runoff of the, so the amount of muscle the vessel is feeding increases, the runoff, which we call. In those circumstances, if you skeletonize the mammary, the hypothesis is that it increases the size of the mammary over a period of time. Now, no one has done a study to see whether it happens or not. But in a skeletonized, one aspect of it is fixed because it will fibrose. The fascia part of it is fixed. Only one aspect is free. So, whether it happens or not is this thing, but that is the basis on which some surgeons practice using a skeletonized mammary.
So to simply understand, skeletonization means completely, clearing internal mammary artery from all its adjacent tissues.
Correct.
Right. And normally they take internal mammary artery along with the adjacent tissues. They don't harvest only artery. All the adjacent tissues of the artery also will be there on their harvested artery. Correct. When they leave good amount of length, so which forms all the loops, which creates problem to your intervention, as happened in this case.
We don't want cardiologists to intervene after we have intervened.
See, another thing, another problem which we face with surgeons, giving venous graft very posteriorly. I think we'll take our KP's views on this. See, sometimes it happens, venous graft is given very posteriorly on aorta.
Right.
So it is very difficult to cannulate. It happened a couple of times to me. It's very difficult to cannulate. Now, what are the situations where you do it posteriorly?
See, normally what we do is we use a side biting clamp, what we call as a side biter clamp. Basically, it is a clamp that will be like, has got two bends. So when we clamp the aorta, it will leave a small pinch of aorta there. So it clamps the aorta at two places, like this. So if this is the aorta, it clamps like this. So that a small bulge of aorta, comes in front, and we make a hole and then do the anastomosis on that. So because we can't stop the circulation. Now, when we use this side biter clamp, we can only use it on either side of it, of the aorta, or in front of the aorta. So many surgeons, they clamp this anterior part of the aorta and put all their grafts. So you will find right and left side grafts coming along a straight line on the anterior aspect of the aorta. But some surgeons, they feel that may not be physiological. So what I do is I practice all the left-sided grafts go on the left side of the aorta, and the right-sided grafts go on the right side of the aorta.
Yeah, this is what we see most often.
Most often. But sometimes if there is calcification or atheroma in the aorta, then we search for a soft spot and put the graft there. So whether if such a thing has happened and that can be a possibility, another thing. Because for us also it is difficult intraoperatively to keep the clamp posteriorly and do anastomosis. So only under very rare circumstances, we where the soft spot is posteriorly placed, then only we could do it like that. So you can show the intraop picture. You have shared.
Yeah. Already. That presentation is over.
Right.
Yeah, I'll just put it again.
I have shared one picture with Sharath, which shows the usual position of so 70 to 80% of surgeons do that way. There are some 10 to 20% people who do it. I'll just have to take this call, sir. Action, sir. Sir, open and put it. So, in this situation, on the left picture, this is what I was meaning, that the left side grafts anteriorly rather than laterally, and the right side graft is it's in the usual position,
right lateral.
Yeah. I don't know
when do you give posterior?
Posterior is very difficult for us also. See, normally my grafts, I don't know whether you can see my pointer on the presentation. My grafts come on the lateral aspect of aorta here, not here. This is anterior. So most surgeons put their lateral, the left-sided grafts come on the lateral aspect, and the right-sided graft come on the, the greater curvature of aorta. As I said, some surgeons put one single clamp and put all the grafts anteriorly, but this seems to be a peculiar situation where, it's neither here nor there kind of situation. But yeah, posterior grafts happen only in rare occasions where the aorta is very atheromatous, and that is the only soft spot that we have got.
And sometimes, after bypass surgery, see, most often these patients are very elderly. So if there is any aorta dilatation, so in those situations, though the surgeon gave it on a lateral aspect, because of its dilatation, it may become a posterior. I think that's the most common scenario, rather than surgeon going and giving in posterior aorta.
Yeah.
Which is not practically possible, right? Clamp it posterior.
Posterior, it's not, as you can see from the picture here, you see this is the thumb of a surgeon. If a thumb also cannot go there, it is very difficult to put a clamp there and do an anastomosis posteriorly. So, I don't think no surgeon would volunteer to do it. Mostly, this anastomosis should be on the lateral aspect or anterior aspect of the aorta.
And another question for you, sir. So, what is the most common cause of immediate post-op ischemia in post-bypass patients? What do you observe in your practice?
See, most common cause of graft occlusion on table or immediate post-op
ischemia.
Yeah,
is a graft occlusion.
Graft occlusion is the most common cause, and you have to exclude that. Most common cause of graft occlusion is a poor anastomosis. Whether the surgeon admits or not, you have to first check the anastomosis that you have done, and because patient safety comes first and ego comes second, we have to always check the anastomosis is working all right or not. So we have to go back, put the patient on heart-lung machine, take over the circulation so that it is safe, and then reopen the anastomosis and check that the anastomosis is not got a clot or anything.
Right. Okay.
So the first common cause of post-op ischemia is graft occlusion. And most common cause of graft occlusion is poor anastomosis. Other causes that can happen is sometimes if it's intramyocardial coronary and we have done an anastomosis, there could be a bit of muscle that could be coming into the anastomosis part. When we do the anastomosis, muscle or some subcutaneous fat can be, the epicardial fat could be coming into the anastomosis, which can trigger off a clotting process. The other thing we see heparin-induced thrombocytopenia is again a very common cause of early graft occlusions, because we will be giving a second dose of heparin during the heart-lung machine initiation. So a thrombotic phenomenon happening could be a cause of early graft occlusion. And how our assistants harvest the vein is also very important, because they stretch the vein a lot, inject saline and make the vein stretch a lot. Then that can damage the endothelium of the vein, and that can also trigger off clotting mechanism.
Any questions to surgeon?
Sir, a question here, sir. Sir, I saw one patient he was an inferior MI patient with RCA culprit vessel. LAD and LCX also had disease, so the patient was taken up for bypass. So post-operatively, he was fine. After 3 days, patient developed an anterior wall MI. Extensive. He was again rushed to ICU. He had VT and all. So at that point of time, what is the point? We manage the patient conservatively. Conservatively, no intervention, nothing was done.
How was the lesion in LAD before? Is it a discrete lesion?
I don't remember very well, sir, because it was about 2 months back.
Is it a discrete lesion or diffuse lesion?
It was diffuse lesion, I believe, sir. So no, sir. I think it was a discrete lesion. Only a proximal LAD had significant disease.
Okay. So in that scenario, I would see. That is very important. If you find a discrete lesion in LAD and you send a patient to bypass because of multivessel disease, right? So in that scenario, it is better you go ahead and open LAD.
The two options remain. If it's a third post-operative day, as you're seeing, and as Sharath was saying, if it's a discrete lesion, you can take the patient to Cath lab and do an angio and check. If the graft is occluded and if it's a discrete lesion, you can stent the vessel and save the territory. The other option is go back to theater and revise your graft. Check the graft and revise.
Okay.
But I would love to do a angioplasty.
Yes.
Rather than research.
Exactly. No. That is good in two ways. Yes. Because a second major surgery in such situation is bad for the patient and patient's body and the heart. So it is a better option if the lesion is stentable in that vessel. Go back to Cath lab and it will give you two informations. One is what is the actual culprit causing. Is it the graft occlusion or is the native vessel that is got occluded? And then you can address it at the same time. So, and with a less invasive procedure.
Okay.
But most often it will be graft related problem.
Graft related, most likely. That's what was said, sir. Because they said suspected more likely to be the graft as the cause. They said it's difficult to intervene and all, and due to social issues.
But you have to ask one question to yourself. If it is only graft occluded and native vessel has only discrete lesion, why would that patient develop an MI? See, most often
what was explained was that thrombus or something had happened at the anastomotic site and it should have completely occluded the LAD.
Yes, that's what exactly happened. Exactly.
So if such a situation, we cannot thrombolize the patient on third post-op day. We cannot, intervention at that point, how do we do, sir? Is it possible to do intervention at the anastomotic site?
Yeah, we can. Of course. See, I'm going through the native vessel.
You address the native vessel, forget about the graft.
You said native vessel is a treatable vessel. Right, so I'll go through the native vessel. Only thing is, he may need a treatment at two sites, at the anastomotic site as well as your proximal lesion site.
Okay. Yes, sir. I don't remember well that LAD morphology, anatomy. So was it discrete or diffuse? I don't clearly remember.
I have seen good number of endotracheotomies. Touchwood, I never had any problem with endotracheotomy done by KP, Krishna Prasad. But I've seen good number of endotracheotomies. Where patient had a diffuse disease. Nearly 20% of the patients will develop acute MI in post-op phase.
Early graft.
Okay.
And I also admit many surgeons leave it. They don't address it. Because I have one VIP done in some, I mean, angio was done with me, but bypass done in some other place with endarterectomy, he ended up in a MI. See, that's the reason whenever there is a diffuse disease, please don't dump the patient on surgeon. Even if you have a triple vessel disease, you analyze it. What will happen to the Lima to LAD? If you think Lima to LAD is a safe, is going to be a patent graft for that guy, then you send it to surgeon. If you think it won't be patent, or if there is some diffuse, if you have some concern about patency of Lima, you please sit with surgeon and discuss, and then you decide. Don't dump the patient on surgeon.
See, one simple thing is, if it's a problem to you, it will be a problem to surgeon as well. So that's a simple philosophy. Surgeon might take the case because he's not having too many operations to do or something like that. He might say, okay, take it. But don't, it doesn't diffuse the situation. If it's a problem to you, it's a problem to the surgeon as well. Second thing is, I wanted to say post-bypass, if someone fibrillates, it has to be Lima to LAD occlusion. It has to be LAD territory. In my book, that is what happens. If post-bypass, someone develops bradycardia, it is right graft occlusion. So you have to go and check. So these are clear markers. And doesn't matter, up to 5th POD, there are instances where we have gone back and revised the grafts. If otherwise the LV is good, patient is a good, good material who would undertake a redo surgery. If the patient's hemodynamic permit, always in a post-operative situation, beyond 24 hours, the ideal thing would be to take him to a cath lab, do an angio, and if there is a angioplastable lesion, just go ahead and do it then and there. But for some reason, after the angio, you know it's a graft occlusion, and for some reason you don't want to do angioplasty. In those situations, take them back to theatre and revise. Up to 5 days, you can do it. Beyond 5 days, it will be difficult because some adhesions form and it will not be the same thing.
But always explore the option of PCI. I would explore option of PCI in all such patients.
Yeah.
If it happens beyond 2-3 days.
Yes.
If it happens on the day of surgery, within 1 hour, then you explore.
Exactly.
Right. And second, and if you want to know what exactly is the problem, you have to do angio on second or third day.
Absolutely.
See, without angio, it's all like assumptions or presumptions in theatre. It is very difficult to treat also patients.
For me, even if it's immediate graft occlusion, what I'll have to do is go back. Say if lateral wall ischemic changes are happening, then for me, I have to go and check the LAD, OM and distal OM grafts, all the grafts. Whereas if you do me on an angiogram that only the OM graft is occluded, then, fantastic for me. I'll just go there and then deal with it and come back. So it's always better to be guided. It's just like, what we do before surgery, guided by the angiogram. That's a roadmap. So post-op, if new changes have come, roadmap has changed. So go back and find the map and then do what is needed.
So during doing a graft on a 3-day anastomotic site on the aorta, won't it injure the aortic anastomosis? Aorta to...
There are two components. Usually the problem lies with the distal anastomosis. Very rarely the proximal anastomosis will be the problem in first few days. And,
yes, but while doing a graft CAG, when we try to engage the graft,
nothing happens.
It will not problem. The stitches are not so loose that they'll come off so easily.
Nothing happens.
The catheter is, the amount of force you can exert on the catheter, with the catheter in aorta is very less. So nothing happens. Yeah, that's a very good question. You might be afraid that, this thing, you might unravel the anastomosis or cause some bleed or something, but no, that doesn't happen.
Very unlikely. Unless you are so crude to do that.
No, it's a simple thing. What I would suggest is with your own catheter, with whatever catheter you want to engage, with the distance at which you are working, push on your finger and see how much pressure you can exert. It's a simple test. You can see, isn't it, with the gloved hand?
Your cannulation technique should be proper. right? The view you are choosing, the movement you are giving. If you have a proper cannulation technique, see, usually you can engage coronaries atraumatically.
Yeah.
See, even native vessel, many people I see, if you see, take LMs, left system, most often you use EBU, right? EBU or this XB, Many people do a traumatic engagement. You will put EBU in the sinus and you will push it down. And then you will try to, cannulate your LMCA. That is very traumatic technique. So EBU, with a simple rotation, see, always you have to keep the tip of EBU at the ostium, right? And that is at the level of ostium, not at the ostium. And give a clockwise or counterclockwise rotation with a little push. That is the atraumatic engagement. So,
okay, guys, bye. I need to be somewhere else. Thank you.
Yes.
Yeah. We'll call Krishna Prasad for all, surgeon plus cardiologist problems. Today is supposed to be with us, giving some insight, but they had some workshop on mitral valve repairs. They are doing, mitral valve repair workshop in rheumatic heart disease. That's why he was stuck in theater. Yeah. Okay then. So I think already 2 hours here. Yeah.
Thank you very much.
Bye. I'm ending meeting. Before ending, the next meeting will be, next talk will be on CT angiography. CT angiography after conventional angiogram. When do we recommend CT angiography after conventional angiogram?